Welcome, hospice clinicians. This recording will introduce you to the new Hospice Clinical Note, which is coming to your Cerner software the week of August 15th. As all the existing workflows are rebuilt to include the new note, it will replace the existing routine note for nurses, the psychosocial note used by the social workers, and the chaplain note for chaplains. It is also meant to be used for documenting the death visit. Once the new note or profile is in use, it will begin to appear down here in your in-use profiles box, and the description will read Hospice Clinician Note. I'm going to click into the note itself to show you what it will look like. This new note is designed to be used by all of the hospice core disciplines, and it has some new sections in it. One here for advanced care planning, which has all of our advanced directive information. It has a expanded pain assessment, which will be great for our nurses. You see down here there's a psychosocial and spiritual section that's been added. And towards the bottom you'll find this end-of-life care section, which has all of the information for charting a death visit. This particular recording will be focusing on the use of the note for nursing documentation. As you first open the note on an admission, you will of course have this top portion, plan for visit. This is the same as your existing note, and it will be blank. Going forward in time, this is where the information from a previous clinician's visit will pull forward. This beginning section, and here let me just move these sections up so you can see these as we move through them. The home environment section and the patient identification section, these are the same as you're already using. They're meant to be used when appropriate. They did change the primary reason for visit. It now reads initial comprehensive routine, PRN symptom management, and recertification. You'll want to select the appropriate reason for your visit. We generally, as nurses in our hospice, do our comprehensive assessment at the same time as our initial assessment. There may be a rare occasion when you may do a quick visit and come back to do your comprehensive, but most likely you'll be checking comprehensive on your admission, and then routine or PRN symptom management for on-call, and recert for your recert visit. Most death visits are scheduled as routine, with the visit type being the death visit, so I would imagine you'll use routine then for the death visit. The home environment section has not changed. The abuse neglect assessment again is available as needed. The emergency evacuation plan, same as we've already taught. I think our best response in hospice is understands and able to verbalize when to contact the agency. That's very important. And then this other community support services section will be used mostly by our social work as they're setting up community support for the patient. So no changes there. You know, in this note functions the very same way as the routine note you've been using, where you can actually click to specific sections of the note, or you can scroll on the right hand side. I will be scrolling through so that we take a look at each of the sections, but know that at any particular time, if you need to move to a particular section of your note, you can do so in this box here. And then of course the lower box, depending on the screen we're in, is going to pull forward any of that look back data that is available. Here's a look at the new section, the advanced care planning section. Anything currently in the chart as you come to this section on a routine note will be listed here at the top. There is a document. These blue hyperlinks take you to some educational pieces. So there is a document here about advanced directives that will open up if you're wanting to learn more about advanced care planning with your patient. Then as you check on any of or as in most of our offices, the social workers will be involved in doing the advanced care planning with the patient. But a feature here, as you check on financial durable power of attorney, it then opens up a box to say that we have a copy of it, or if we're requesting a copy, it'll open up a narrative box on who we've made, that request from. We can also, on other, it's going to open up again a box where we can fill in what that other document is that they have, and whether we have a copy or we've requested a copy be made. Here's our post for Idaho, post for Utah. List here if those are available. Another thing added to the new note, gratefully, are the sections for the HIS data to be collected. Please keep in mind on the preference, which is that tab F, notice the F2000, so these are labeled. On this section, we do have to show documentation of the discussion. So while they're asking the specific questions here, was the patient asked about preferences for CPR, and you can certainly answer the question, we also need to go to the summary field you'll see at the end to document our discussion. The hyperlink takes you right into the HIS manual where the explanation of how these questions and why it's being asked is explained. So that information is available to you at any time. So you will, as clinicians, actually be answering these questions, and then in the office we will continue with our process of the HIS itself being reviewed and signed by our combined team and efforts of our office managers and directors. All right, so moving right through this, after the question on CPR, there's a question about life-sustaining treatments and about hospitalization preferences. Again, it's great to answer these questions. Please answer them correctly, and then make certain you come to this box that says Advanced Care Planning Supporting Documentation and give the answer, the explanation of your discussion. Okay, and go ahead and type in there what you talked about and what their requests were. All right, our next section is our vital signs and measurements section. This functions very much the same as the current note that you're used to using. As you enter in a height and weight, a height in inches and weight in pounds, it will calculate convert everything over to centimeters and kilograms for you, and then it will also calculate the BMI down here. They're having you enter in the mid-upper arm circumference in inches. Actually, I just put a centimeters in there. That was great. and it does the conversion for you. One thing that has been added in this vital signs section is an opportunity to say that something was not done, a pulse was not taken or declined. And when you click those boxes, it will bring up a reason box for you to type in what happened there. You do have the ability to add multiple temperatures, multiple respirations, and multiple blood pressures. That was a concern that someone had about our routine note. Or you can do an SpO2, but both at rest and after exertion. As needed. You're able to put your vital signs in here the way you've been doing them. Again, there is a documentation narrative box available. This note also, I'll go ahead and click to the cardiopulmonary section. At the beginning gives you the chance to open up assessment details. So as you come to cardiopulmonary and click assessment details, it then loads for you to put in additional cardiopulmonary information. And you can simply come through and mark those things that are appropriate for your patient. On the observations, it does bring up as you click, and this is a feature throughout a lot of the note now, it brings up additional fields that are appropriate when you check on them. I check on RALs, now it's going to ask me where it is, so I think you'll find that that's a great feature. It has a specific question about shortness of breath, and this is the section where we will go to for the tab J in the HIS section on dyspnea. There is what's called a modified Borg rating scale for perceived dyspnea. This is simply a descriptor that kind of gives you, depending on how they say it, allows you to kind of give a 1 to 10 scale on dyspnea. At this point in time, Medicare is not acknowledging this as, to my knowledge, as a formally recommended scale for dyspnea, but it does look like a great way for us to notice if it's getting better or getting worse by using these descriptor words when people describe their dyspnea. And there is an explanation page as well that you're welcome to read through if you want to see that little description. Respiratory treatments. Again, a lot of these fields, when you click into them, are going to, is oxygen present? We check yes, and then up comes all of the information about the specifics about the oxygen. So you're going to have an opportunity to add that additional information. Same thing with our cardiac status and cardiac devices. On cardiopulmonary education and training, interesting here, we haven't hit the care plan section just yet. And it gives you an opportunity right here to pull in care plans that are specific to the cardiopulmonary system, if you have those. Now, on admission, of course, those will not be available yet. Okay, so if we did have cardiopulmonary care plans in here, we would, on a routine visit, for example, you would be able to come in here and select the goal and the intervention that you're using on that visit, and then you can click in here and type some additional information towards that goal and that intervention. Okay. We also have in our teaching, these will open up additional fields, and then your cardiopulmonary status narrative space at the bottom of the cardiopulmonary section. All right. Our care plan section is just like the one you're used to using. In the routine note, you'll be able to pull in any active problems that you're addressing during this visit. You'll be able to address the goals that you want to bring into your note, add that to your note, and any interventions that you're going to be addressing in your note. And then you have the opportunity again to type additional information regarding those goals and interventions with your patient on this particular visit. Once more, as we progress down, let me mention one thing on this. We do have an opportunity here to show that when the care plan was updated. Remember, with each visit, you review your care plan, you do your visit and assessment, document your findings on your physical assessment, then you have an opportunity to go back to the care plans and add any additional interventions needed or interventions that have been completed and goals that have been met. Then we update our final note, come back into our note and pull in those things we've added. So here we get a chance to come back in and say we did update the care plan, or the patient and family participated in developing the care plan today. And that's an important thing for you to be able to document. And then our narrative space once more. In your previous note, as well as in this one, there is a section for history and diagnosis. As far as admission and recertification go, we open up this section. It's really focused on hospitalizations, which generally it's a discharge and then coming back. So this is kind of a section that's a little more geared to home care. And I would recommend that we put our patient history and diagnosis history in our LCD screens on admission and recert, just like we're doing now. And that form has not been changed. The next section we'll come to is medications. Once we've admitted the patient and added their medications, and on our routine visits going forward, any meds currently on the med list will appear in this box for our review. And we have an opportunity to make sure that we know who is managing the medications, if it's the patient themselves or someone else. When we click others, it would be really good to come down into the supporting documentation box. And this is where you could put a note about the medications being safely administered in the home. There is no reason for you to evaluate the employees of a facility If they're in a facility and not at home, then that is who is managing their medications. All right, then we head into several of our physical assessment areas. I would recommend, if you're not going to be charting on that section, to just leave it blank. Please do not check no problems observed or reported. We don't need to be focusing on that piece, but we do want to address any particular concerns. So in this neurological and behavioral section, if that's an appropriate section for your visit, you're going to click the assessment details, and then it will open up for you. Again, this is very similar to the note you're used to. Orientation, pupils, there is a portable mental status exam, and this again is being used a lot more by social work than by nurses, but it is available to you. Neurologic symptoms, again, these are all going to open up. If I say I have weakness, it's going to light up. Is it in the arms or the legs? I click it, and then it wants to know the location. So things are going to continue to open up as you click into areas. Behavioral status has a behavioral health screening tool as well, which is again available for social work to use, and a narrative box at the end. The psychosocial and spiritual section is newly added. This is where the social worker and chaplain will be doing the bulk of their documentation. When you check into psychosocial, it brings up some different some tools that they'll be able to be using. A section on chemical dependency. This is where the bereavement risk assessment is. When we click into bereavement risk assessment, it's going to open up that entire piece. And there's a spiritual and existential area as well. This is the section where the documentation about asking the patient about their spiritual concerns will be located, and the discussion, if you're the one having that discussion with the patient, please document your discussion in this narrative box at the bottom of the section. I'm going to go ahead and click on that. It has our tab F question on spiritual preference here, and then also an opportunity for them to pull in any psychosocial and spiritual care plans on their visit right in this section. Okay, you'll probably want to kind of click through some of this when you first see it and just become familiar with what's here. The sensory and status and EENT sections are going to be exactly the same. You'll have an opportunity to click in and use the fields that are appropriate. I'll just go ahead and open it up and kind of scroll through that. Again, additional fields will open up and light up as you make selections, and you'll be able to document appropriately there. I do want to show you on the comfort and pain section, they did make the comprehensive pain assessment so that it includes now all 7 pieces of the pain assessment. Very nice addition. Please keep in mind, as I go through this section, that we can do a comprehensive assessment on every patient, whether they're responsive or not, whether they can answer the questions or not. If you've completed your HIS training, you had a little additional information on how that is done. When a patient is not responsive, the way we determine what makes it worse, what makes it better, how does it affect quality of life, is through interviewing the caregiver. If a caregiver can't answer, then you simply chart caregiver unable to determine what makes the pain better, what makes the pain worse, or unable to determine how it's affecting quality of life. That simply shows in your documentation that the assessment was complete, even though the information was not obtained. We did do the assessment, and that's what the HIS is evaluating us on. As we come into this section, we now see the one absolute mandatory field that we will have, and that is, was the patient screened for pain? That question needs to be answered on every time we come in the note. We will always be screening the patient for pain. These fields here are very similar to the routine note that you are currently using. And you can see if I say yes, I was screened, I'm now going to be selecting the date that the screening occurred. This information is going to be transferred over to the HIS data on admission. I have a chance here to say what the highest pain severity was during my visit. I have a nonverbal pain assessment for that to determine what that pain severity is for those who are nonverbal. Okay, and that's the approved pain ad, and the score will come down here depending on your answers in the pain ad. And then we can determine what type of tool was used. In our particular office, numeric is all of our 0 to 10s. Staff observation of our non-responsive, or the pain ad, is a staff observation. Patient visual would be the faces scale that we use with people that shows the picture of the face and they choose. And to my knowledge, we do not currently have any of the approved standardized verbal descriptor scales available to us. So this would be a very rare, if you're familiar with your HIS training and what one of those is, you could use it, but I don't know of any not available in this documentation or trained in our offices. Now I'm going to scroll back up. I want to show you in the pain, when they do screen yes for pain, then we're going to be adding the comprehensive pain assessment. This is very similar to what is done in the routine note. You would click add, you're going to put in your location of the pain, the date that the pain began, and we're going to add this location to our current list of pain. Then it's going to open up when we select that, and I'm just going to move down on this one. I select it, it opens it up, and then I'm able to answer the remaining questions about this particular pain. It's going to open up previous documentation here, but what I'll be on admission, this will be blank, and we'll be adding the first location. You'll talk about character. We've already identified severity, right? That's our number. We've got our location, we've got our character of pain here. This is the one step that you will not be able to obtain from a non-responsive patient. Everything else you can. Select the level of the pain that the patient is exhibiting. Ask them what their acceptable level of pain is. That helps us know if they're above, below, or if they're okay. It does have you then convert their actual pain to a severity name, which is the way it is categorized in the HIS. How frequently is the pain occurring? They can choose the appropriate one there. And then they've added these lists, effect on quality of life. And if we do collect other, we have a way to go in and document in a narrative field what other is. Otherwise, we collect click on what it affects. Our exacerbating factors, this was not on the previous pain scale. We're now able to identify what makes the pain worse, and we can click on what's appropriate there. And relieving factors, this tells us what makes the pain better. Heat, cold, rest, whatever it is that's making it. Okay. So that information, once that is saved, will then filter into the table that is created showing the pain and the dates and your assessments. But this is where our individuals filling out the HIS will look to see if your comprehensive assessment was done. And then at the bottom of the pain and comfort section, you have an opportunity here to document any additional information. So if the caregiver was unable to identify what makes the pain worse, that shows that I did my assessment. I may not have gotten an answer, but I did not miss that piece of a comprehensive assessment. And then any other information you want to record about that particular pain. All right, moving on down through our other sections. Let's just kind of scroll down here. We next go to the GI, GU, and reproductive, and this is where we would document any bowel regimen. Again, we have, you can see these different sections, and as we open on the assessment details, it's going to open up information for urinary, and all of these we could click through. If I click on urinary catheter, it opens up and I can now add the catheter and put the type, the balloon size, the insertion date, and so on each urinary catheter. If I click on type of dialysis, it's going to have me mark that and so on, and it'll continue to open up those windows. If I click that I have abdominal gastric issues, it's going to open up another list for me to choose on what kind of abdominal distress I'm having. If we click on that we have bowel sounds present or diminished, we can go by quadrant here for the bowel sounds and bowel function. And notice we have actually a narrative space for bowel aids used or bowel routine. So here's an opportunity to very clearly identify what your patient's bowel regimen is, and this is where our people completing the HIS will be looking for guidance. If there's something in the med record, they'll be checking the med record, but you have an opportunity here to identify that information. Okay, the reproductive section, I think for most part in hospice, you're just going to skip right over. It's not going to pertain to a lot of our patients, but it's there if you need it. Use it at your discretion. Nutrition and endocrine, again, we'll click on assessment details. I would recommend not ever charting no problems. I think no charting at all is better than no problems. Changing in appetite, increase or decrease, then weight gain, weight loss. If I put that they've lost weight, it's going to come up and want to know if it's intentional or unintentional, and then how many pounds, have they lost. The meals they're eating, the BMI we calculated on the vital sign screen is pulled into this section, so we can have that available here. And then you have a chance to talk about specific diet issues, alcohol use, questions about diabetes. If I'm going to come in here and talk about blood sugars being done, it's going to let me set up parameters of when to call the doctor. It's going to give me more information about the blood sugars, etc. Again, encouraging you to kind of take a look at that section. The infusion therapy labs and treatment section. Again, if we're doing infusion therapy, it gives us a chance to add those locations and therapy types with IV access and dates. Peripheral IVs if they're inserted. On the home test for labs, this gives you a place where you can put in your, if I want to add one of these, I can put in the name, and you could put your PTINRs in here and create a table that will show those lab results and other lab tests. So that'll be great. And there's a big list of treatments. If you go into this treatment section, a lot of different treatments that we sometimes see done in the homes when we do our visits with our physicians. And you can check and see if those special treatments are there, and then click in and do the additional documentation for those. Our next section is on wounds. This section is very much very similarly laid out as the one in your current routine note. You can select the different types of skin conditions, and then there is a Braden scale in here that you can click on and complete. And then also on wounds, you would simply click add, and you can put in the location, length, width, and depth, the type of wound, the stage of wound, and the descriptors on that, and you can follow, and it will build that information right here in this table under your integumentary wounds. And of course, you've got your narrative space where you can come in and finish up your narration on additional information. Musculoskeletal, once more, that's available as needed. There are some physical therapy, again, areas to track PT function in here, and I would say that these would be very helpful if you have a physical therapist seeing your patient. They may want to use this note and use these sections to document what they're doing. You're welcome to look through that and use it if there are things appropriate. The ADL and IADL sections are the same as in your prior note. There is a tug test section in there for use as needed. Fall risk factors and history. This does have a Mach 10 in here to do a fall risk, and if the patient does fall, it's going to open up where you can add each time there's a fall and indicate when it happened, how it happened, what the resulting care was, and whether or not the physician was notified. Then of course you have your narrative space to be specific to the fall. Care management and coordination of care. This is a section that's used quite a bit by home care. You're welcome to look into that and see if that's something that would be helpful to you. Emergent care and intervention synopsis. This section is really meant to document hospitalizations and track the patient going in the hospital and coming back onto home care. Again, I don't see us using the tracking of hospitalizations in the middle of a visit. Usually we would have a discharge, we would bring them back on, and their history of hospitalization would then be in our history. So you're welcome to investigate that section. The summary field is very much the same as your existing note. This summary is used, we were using it on admission for our HISDA conversations. Those now have a specific location higher up in our chart under our advanced care planning and in our spiritual section for those conversations. In a routine note, this would be your space to summarize your visit. You can add that summary. New sections on this note, though, are this end-of-life care. When you click on pronouncement details, it's bringing up a section for observations. Again, when we click other, it opens up a narrative field for you to put in who completed and created those observations. There is a location for the time, date and time of pronouncement of death, the person making that pronouncement, the physician that will be responsible for signing the death certificate can be on here, whether or not the patient is an organ donor, and family support and people notified, followed with a narrative space, which is where we could put the death summary of the death visit. We also have our coordination of care. Once the death has occurred, who have we notified? We can indicate here the people we've notified. And a completely separate section for post-mortem care, where you're able to indicate the things that have been involved in performing post-mortem care, whether or not an autopsy was requested. Now, they do have a section here for disposal of medications discussed. So this is you teaching the family about medication disposal, and you can put here what you taught them about. I would recommend that you be familiar with the current DEA, that we cannot physically take those drugs and dispose of them away from the family, but we can indicate that they agreed with us or that they know about it, what we taught them, and then put any kind of description of our death visit here in the end-of-life supporting documentation. And then the final section, our plan for next visit. This would simply be you, if there's some specific items the patient's concerned about and you want to make sure whoever comes next to see the patient is aware of that, you can put that in here in your plan for next visit. Something that the patient is particularly concerned about, you can put that in there, and the person coming to visit next will now see that at the first of their note to alert them to something that they would want to follow up on with the patient. Okay, good luck with this. I think as you explore it, there are some really nice features that are very much geared for hospice now. It'll be very nice to be in a hospice environment as we're doing our charting. And if you have any specific questions, please call extension 4119 or 397-4119, and we'd be happy to help you with those questions. Thank you.